So today we've been called out to the Auckland Museum to a 24-year-old female who has shortness of breath. She's somewhere in the museum, so we'll go and look for her and we'll do our assessments. However, we've got some vitals. Her heart rate's 130, her blood pressure is 90 on 60. She has a GCS of 15, but she's saturating at 92%. She's got a temperature of 36.7, and apparently her risk rate is quite high. So we're going to go and find her now, and we're going to go over our assessments and come up with some diagnoses. So upon finding my patient, I can immediately notice that she's in the tripod position. She's really working to get her breaths with her accessory muscles. She's even got blue lips indicating cyanosis, and her fingers are looking quite pale and not well perfused. Hi there, my name's Sam. What's your name?
Sarah.
Hey there. I'm with the ambulance. What have you called us here today for?
I can't breathe very well.
Can't breathe very well. Do you mind if I just take your pulse and ask you a couple of questions? Okay. Have you had anything like this happen to you before?
No.
No. Okay. Her radial pulse is quite fast, but it's not bouncing and it's not strong. It's quite weak. So I might be concerned with a circulatory issue, but my first and primary issue is trying to solve and figure out what this chief complaint is. So Sarah, you've never had anything like this happen to you before. Were you doing anything when this happened, or?
No, just walked straight out.
You just walked around and you just felt the need to sit down. Okay. Yeah. And you don't have a history of asthma, or you're not a smoker?
No, never smoked.
So given that she's not a smoker and that she's not asthmatic, I'm not going to be expecting to hear a wheeze, just because these would be things that would indicate bronchospasm, and that would be the sound that I would be listening to. So Sarah, I'm just going to auscultate your chest for a moment just to see if there's anything wrong with your lungs. Take a deep breath for me. Take a deep breath for me. I'm also going to listen to the back as well. And lastly, I'm going to look at the lower lobes. So Sarah's upper airway does actually have a wheeze, which is unexpected, but in the lower airways she's also got crackles, which would indicate that Sarah's actually got fluid in her lungs. Now, fluid in the lungs can typically be caused by things like pneumonia, if somebody's inhaled water. So Sarah, have you had an illness within the last couple of days at all?
No.
So given that Sarah hasn't had an illness in the last couple of days, and her temperature is not radically elevated, the chances of her having pneumonia or an infection causing the fluid in the lungs isn't very likely. So Sarah, do you have any other discomfort elsewhere at all?
A bit of tightness, and it's like this dull, thumping pain.
Dull thumping pain in the chest.
Yeah.
Does it go anywhere?
No.
Does it go to your jaw, down your arm?
No.
You don't have any abdominal pain or back pain?
No, we're okay.
No, so it's just in the centre of your chest.
Yeah.
Do you feel like your heart's racing?
Yeah.
Okay. So given that Sarah's pain doesn't seem to radiate to the jaw or down the arm, it wouldn't fit the textbook definition of a heart attack. However, you'd need an ECG anyway to confirm. But no abdo pain and no pain radiating to the back doesn't indicate abdominal bleeding, but we can check for that as well. But back pain wouldn't indicate, with the lack of back pain wouldn't indicate that she has a AAA typically. So Sarah, I'm just going to get a 3 lead and put that on you. But because you've got chest pain, you are actually going to have to come with us to hospital. You are going to be treated as a priority 1. And at this point in time, we could call for backup, or we can immediately transport. But I'm just going to do a couple of other assessments, because I am actually kind of noticing that if you hold your breath for a moment, you can actually see that Sarah's jugular vein is actually distended, which means that there's a backlog of blood that's ending up filling up her jugular vein. And it seems to be about 2 to 3 centimeters long, so it's getting there, and that's leading me to sort of suspect that she's got right-sided heart failure, which we would also typically see as pitting edema in the feet. And if I push on Sarah's ankles, my finger has left an indent and it's not bouncing back like normal skin would, which would indicate that's filled with fluid and that she's got pitted edema as well. So I'm quite comfortable to say that Sarah's got right-handed heart failure, and the crackles in her lungs could be indicated by left-handed heart failure as well. So I'm quite comfortable to say that Sarah's got left-handed heart failure that has then become right-handed heart failure, leading to jugular distension, pitted edema, but is the cause of her shortness of breath today. Hey there, so just to wrap up that video, there are many different causes for shortness of breath, such as like asthma, anaphylaxis, cord, smoking, smoke inhalation, burns, pneumonia. So it's important that when doing your assessment you're able to differentiate between the different symptoms that the different causes for a particular chief complaint can be. So with things like pneumonia, you will have crackles in the lungs because of fluid. With something like asthma, you will have bronchospasms causing a wheeze, or with anaphylaxis you might hear stridor because it's an upper airway obstruction, things like that. So that's why performing an auscultation is important, because if you're able to differentiate between what the patient may or may not have, you're able to then develop a proper treatment plan. But the purpose of this assessment was to just demonstrate that that ability to analyze assessments and come up with diagnoses, not so much the treatment plan of the patient. However, just going to talk a bit about Sarah's chief complaint being left-handed heart failure, and the way that we came up with that diagnosis was just based on her systemic symptoms. So with left-handed heart failure, you tend to have reduced cardiac output. By reduced cardiac output of the left-handed heart, you're not having blood go around the body properly. So you'd see lack of perfusion in her peripheries, cyanosis because of lack of oxygenated blood, delayed CRT, and things like that. You can also see it in things like the fact that she was tachycardic. So the heart's trying to compensate for its reduced output by speeding up, and the reduced blood pressure, which means that there's not as much efficiency behind that blood flow. And with left-handed heart failure, you tend to have a backlog because it's not pushing blood through adequately. You have a backlog of blood that occurs in the pulmonary circuit, and this increased pressure within the vessels in the pulmonary circuit causes fluid to leave the vessels and into the lungs, causing the crackles that we heard without auscultation. We were able to rule out other causes of crackles, such as pneumonia, by asking the patient, have you had any recent illnesses, and her temperature wasn't elevated, so it probably wasn't an infection, which rules out pneumonia on the most part. And then with this backlog of blood in the pulmonary circuit, you end up having a backlog of blood in the right hand side of the heart, and this again causes further symptoms and complications, such as because there's a backlog on the right side of the heart, the superior and inferior vena cava aren't able to offload blood into the heart efficiently, which means that you'll have jugular venous distension or jugular vein distension due to the fact that it's not able to remove the blood from the system back into the heart. So you have a backlog going up, and you would also see things like pitted edema in the feet as it's not able to, again, leave the veins efficiently, because the right hand is blocked by the left hand because of the backlog between the pulmonary circuit.
And we discovered that she had, venous distension and pitted edema later on in the video, and chest pain and things like that. However, to diagnose something like left-handed heart failure, these things are all good, and they're really strong indicators that this is what the problem is. However, something like an ECG would be needed to confirm. We didn't really go into this in the video just because of the length of it and explaining how to interpret the ECG and determining that. It just seemed like too much hassle. But hopefully this was a good demonstration as to how to have an array of symptoms and try to figure out what is which and what corresponds to what pathophys, and being able to knock a few out and try and figure out what the actual problem with the patient is.